Hello everyone, this is Gregory Hartman from NARAL Pro-Choice Colorado. We're just going to wait another minute or two to get started as folks are slowly filtering in. But I did want to welcome those of you who are already on to this month's webinar. We are delighted to be joined by Colorado Consumer Health Initiative today, and we also have some speakers from other organizations which will be introduced in a little bit. But thank you so much for joining us today.
All right, well, welcome to No Limits to Women's Health, Overcoming Key Barriers to Access webinar. Hello, my name is Amber Burkhart, and I'm the Health Policy Analyst at Colorado Consumer Health Initiative. Colorado Consumer Health Initiative and NARAL Pro-Choice Colorado have partnered together to bring you this webinar today. So in this webinar, we will learn about the resources and tools necessary to talk to women about the copay-free preventive services available to them. The material focuses on the Affordable Care Act's key reforms for women and unique barriers specific populations face in accessing preventive services. The webinar will also dive into ways that women and the organizations that advocate for them can successfully navigate these obstacles. Our guest speakers include Karen Davenport, the Director of Health Policy at the National Women's Law Center. Karen has focused her career on advocacy, research, and public policy development dedicated to improving America's access to health care. Today, Karen will be talking about the Affordable Care Act's key reforms for women with an emphasis on women's preventative services. Renee Butine is an adult advocate and health educator at Advocacy Denver. Renee is passionate about community, healthy living, and equal rights amongst all. Today, Renee will be talking about some of the unique barriers women with intellectual and/or developmental disabilities face accessing preventive services. She will also be talking about the tools organizations can use to help IDD women overcome these barriers. Myrna Castro is the manager of ENTRA and the Coalition for Culturally Appropriate Response and Enrollment Services. Myrna has been integral in the growth and change of the health advocacy program at Servicio de la Raza. Myrna will be talking about some of the unique barriers Latina women face accessing preventive services and the tools organizations can use to help Latina women. Lastly, my name is Amber Burkhart, and I will be talking about a complex barrier that dependents often face when seeking out confidential health services in the private health insurance market. And Karen is going to start us off today.
And before we begin, I do want to remind everyone to ask questions throughout the presentation. We definitely welcome that. On your screen, you should be able to see a portion where you can type in questions, or you can also raise your hand. And please feel free to raise your hand if you have any problem with audio or visual at all throughout the presentation. And with that, Karen, if you'd like to lead off.
Great. Thanks so much, Greg and Amber. I'm going to provide a little bit of background on the Affordable Care Act reforms that are particularly important for women, just so that we're all working on the same baseline. I'm sure everybody's very familiar with that. And then I'm going to focus on, particularly in preventive services, and highlight some of the plan, policies, and procedures that create barriers for preventive care on a more general sense, not to the targeted populations, because we'll get to that later in the webinar, and point to some resources that my organization, the National Women's Law Center, has for women who have trouble accessing preventive services. So we can move to the next slide. The basics of the Affordable Care Act are really the three-legged stool of coverage, how it reformed the health insurance markets and created the health insurance marketplaces and established premium tax credits to help pay for marketplace coverage. And within that, created new coverage requirements for key health services, particularly prevention, prescription drugs, and maternity that are very important for women, and those requirements apply to most types of health insurance. And then lastly, the other key coverage piece is that it required states to expand Medicaid coverage to all individuals with incomes below 138% of poverty. And then there's an error in this slide, which is that it is an NFIB versus Burwell, the Supreme Court versus Bailey has made this eligibility expansion optional. We've had too many Supreme Court cases about the ACA, and I was clearly moving too fast making these slides. Anyway, if we can move to the next slide. So the ACA I really think of as being such an important change in terms of women's health, partly because of how bad things were for women before the ACA was passed. And as you will remember, insurance companies in the individual market could deny women coverage if they had had, for example, a C-section with a previous pregnancy. They could charge women more simply for being women. They could charge men and women more if they had had serious health problems in the past. And very often plans in the individual market didn't cover key services such as maternity care or prescription drugs. On the Medicaid side, before the ACA, states could, and in many, without getting a waiver, generally had to cover only categorically eligible women, which meant that if a woman was not either elderly or disabled or pregnant or a parent, she could be, her income could be half of the poverty level or lower, and she would still not qualify for health coverage through the Medicaid program in most states. And they could also set visit and prescription limits for enrollees that really meant that Medicaid didn't meet people's needs, including for services like preventive services. Next slide. So things have really changed. Now insurance companies have to sell coverage to all applicants. They can only vary premiums based on age, family size, whether somebody smokes, and where they live. No more gender rating. They have to cover all essential health benefits if they sell in the individual or small group markets, and that includes preventive services. They can't charge cost sharing for prevention. They also have to include maternity and prescription drugs. And they need to abide by rules that prohibit discrimination on the basis of race, color, national origin, sex stereotypes, gender identity, age, or disability. So that means that they cannot have a benefit package, for example, that provides richer benefits to somebody who is a male versus somebody who is a female, for example, or design a benefit package that may be particularly favorable to people who are of one age or another, or exclude services that are important to people who are transgendered. Next slide, please. And then on the state side, states may now offer coverage to all women with incomes below 138% of poverty. They can also improve the preventive services that they offer for traditionally eligible individuals, in part because they can get additional matching funding for doing that. And the states that expand Medicaid eligibility must cover all essential health benefits, including preventive services. Next slide. So to dig a little bit deeper on prevention, the ACA requires most health plans to cover preventive and wellness services and chronic disease management as one category of essential health benefits. And that coverage has to include all services with an A or B recommendation from the United States Preventive Services Task Force. So some examples are clinical screening services like cervical cancer screening, colon cancer screening, mammography, blood pressure screening, cholesterol screening, and also counseling services like tobacco use counseling. Children's preventive services, which are defined by Bright Futures, which is a set of guidelines that are largely managed by the American Academy of Pediatrics, and women's preventive services following guidelines that are put out by HHS. And so those services include birth control, breastfeeding supports and supplies, well-woman visits, and intimate partner violence screening, as well as a couple others I didn't get on the slide. And these services all have to be offered without cost sharing, and also vaccines as recommended by the ACIP. Next slide, please. So, I think one of the unheralded things about the ACA is how much emphasis it put on prevention, and we won't get into where some of the other pieces are. This is for a number of reasons, and one is just how prevalent preventable disease is in this country, and also that the benefits of preventive services. In some cases, they can reduce your risk of acute or chronic disease, for example, immunizations, obviously, or doing cholesterol and blood pressure screening, which can then lead to appropriate interventions. And then other preventive services, such as some of the clinical screening services, they can identify disease early when treatment can be more effective. Something that we focus a lot on at the Law Center is how preventive services help women manage their health. I'm thinking particularly of the Well Woman Visit, which is part of women's preventive services, and that really gives women an opportunity to engage in the education and counseling and other kinds of interaction with their primary health care providers to understand what they need to do to stay healthy and to get themselves healthy and stay healthy, I guess I should say. And then there's evidence, although it varies in its strength, that prevention lowers healthcare spending and improves economic productivity. It's certainly more true on the mass scale than from a health plan perspective, where they're worried that you might not belong to their health plan in the next year. And that may explain some of the problems that people have when they're accessing preventive services. If we can have the next slide. So women can be covered for preventive services through a variety of coverage avenues, and this slide just goes through what some of the requirements are. Most people still get their coverage through employer-based health insurance, and for employer-based plans that are ungrandfathered, which means that they have had some changes in their cost-sharing structure or their benefit design since the ACA passed. And at this point, that is about 75% of plans. They must cover preventive services without cost sharing, and that's in those categories I outlined before. All plans that are sold on the marketplaces must cover prevention without cost sharing, and also individual and small group market plans that are not on the market, that are not offered on the marketplaces, but that serve the individual and small group must as well. In states that implement the Medicaid expansion, women who are covered through that particular way of being eligible for Medicaid must also have ACA level coverage. And then traditional Medicaid is more of a mixed bag, and that really depends state by state on what kind of preventive services the state has decided to cover through the state Medicaid plan. But I do note there for children who, depending on the state, can include adolescents up to the age of 21, they are guaranteed what's called early periodic screening, diagnosis, and treatment services, which means that they can receive anything that's in a state plan if that's something that they need. So regardless of how the state Medicaid plan has been designed for the younger women you may be working with, through EPSDT, they at least in theory, can qualify for richer preventive services. Next slide, please. So those are kind of the broad rules, and want to talk a little bit about where there's been guidance that is drilled down to help define what some of those services really mean. And the two examples that I used were birth control and breastfeeding, although I'm happy to answer questions about other kinds of services too, where there has been guidance. First, on birth control, there's been a series of guidelines guidance put out by the Departments of Health and Human Services, Treasury, and the Department of Labor that lay out what health plans need to cover. At this point, where we stand is that plans have to cover, without cost sharing, all birth control methods included in the FDA birth control guide. So there are 18 different methods in that guide. They differentiate, for example, between different kinds of the pills. So a combination pill versus a single type of pill, and then the level of dosage. Some of those are different kinds of methods. They don't have to cover every particular pill that's on the market, but they have to cover at least one without cost sharing within each of those categories. And then coverage also includes over-the-counter birth control, and particularly for women who are having, say, an IUD inserted, follow-up services, management of side effects, and device removal if that's necessary. So, for example, if a woman is getting an IUD, a common practice is to also do an ultrasound to make sure that it has been placed properly, and so that ultrasound also has to be covered without cost sharing. Plans are also required to defer to the woman's provider to determine the medical necessity of a particular service or FDA-approved item, and whether that is, in fact, the birth control method that is best for her. So the medical management that the plans can use does not supersede what the attending provider determines is what that woman needs. Breastfeeding, we have less specificity, but they have clarified that breastfeeding benefits include comprehensive support and counseling by a trained provider and the cost of breastfeeding equipment that can be either rental or purchase, and that coverage applies in conjunction with each birth for the duration of breastfeeding, and that is a duration of breastfeeding that is defined by the woman, not by her health plan. Next slide, please.
Karen, we actually do have a question for you. One of the audience members would like to know, does coverage mean that birth control is free? Or what exactly does coverage mean?
So it means that within each of those categories, there needs to be, of methods, there needs to be at least one of one item on those within those methods. So one particular pill or one particular kind of IUD that is free, that is covered without a deductible, without coinsurance, or without a copayment.
Great, thank you.
And if we go to the next slide, that will be hard to see, but that is the FDA birth control guide. And as you can see, it goes through different kinds of barrier methods and pill methods, and I apologize that it is so hard to read, but you can also pull that up pretty easily if you Google FDA birth control guide and take a closer look at it, but that'll give you exactly how their taxonomy, so to say, for how they come up with all the different methods of birth control. And I should say this has been a really big improvement from where we were, say, 6 months to a year ago, where a lot of health plans said that they covered, one method in each category, and the categories would be hormonal, barrier, sterilization, so that they could cover, they could really limit what they covered on the pill, for example. Next slide, please.
Okay, and Karen, we actually do have another question, and it's
Sure.
a few slides back. It said most, not all, plans must provide these services at no cost sharing. What are those other plans, and who is affected, is the question.
So the plans that don't have to cover these services without cost sharing are the grandfathered employer plans, and then also, well, basically that's it. The grandfathered employer plans, and then employers who are also religious organizations in the case of birth control, or religiously affiliated organizations, or nonprofits or for-profits that are closely held corporations, and that is the Hobby Lobby case from the Supreme Court that reaches to them. But for most people, it means that if you work for an employer who has not changed their benefit design since 2010, there are, the data came out yesterday, about 25% of employer-sponsored health plans are still considered grandfathered, and they are not required to cover these services. There is not really good information about how that applies across size of employer or sector of employment, but it does mean that most women who have employer-sponsored coverage these days do have coverage for these services without cost sharing. But if you're working with a woman who's having trouble getting her preventive services without cost sharing, for sure one of the first things you need to determine is whether her plan is grandfathered or ungrandfathered.
Great, and that actually brought up another question, and that's how long will these plans be grandfathered for, and then will there be points in the future where all plans will need to comply?
So I guess in theory, a plan could stay grandfathered forever, but that there is no actual time limit by which they need to change their grandfathering status. But practically speaking, health plans and employers, do end up changing how they are, what their deductible level is, or how much they charge in cost sharing, for what kind of copayment they have for a specialist visit or an ER visit or something like that. So the expectation is that over time, virtually all plans will be ungrandfathered. I don't have a particular window for you on that, but there is just enough employer interest in changing up their benefit designs and, frankly, shifting more costs onto enrollees that most of them will lose their grandfathering status at some point or another.
Okay, and we do have another question on this, and it was actually in regards to breastfeeding. Are breastfeeding equipment such as pumps covered, in particular by Medicaid?
So that is a much trickier question to answer. We don't have very recent information on which states cover breast pumps and which states do not. The last information on this was a survey that the Kaiser Family Foundation did in 2008. Pumps and other breastfeeding equipment and then lactation support as well is an optional service under Medicaid, and there are a number of different ways states can cover it, but they don't have to. And if I remember that data right, it was that roughly 2/3 of the states covered breastfeeding equipment, and something less than that, like about 20 states covered lactation counseling. And the best thing to do for your state is to check with the Medicaid agency to see what is covered. Would also say that for women who are Medicaid eligible in states that do not cover pumps, WIC can also be a very good source of for pumps, that WIC will provide pumps for free for women who qualify for WIC. And if a woman has qualified for Medicaid, she's very likely to qualify for WIC.
Thank you. And we do have a few more questions from the audience, but I'm actually going to ask folks if they wouldn't mind waiting till the end and seeing if some of these questions are answered in the upcoming slides, and that way we can go over all the questions at the end. So Karen, I will move on to the next slide for you.
Okay. I'm just going to touch on some of the common problems that we have seen with preventive benefits. This is based both on a hotline that we run, which I'll touch on a little bit more in a minute or two, and then also research that we have done looking at the plan contracts for plans that are offered in marketplaces in 15 states. So some of the problems we see are plans that, even though they're not allowed to, are still charging cost sharing for preventive services. What happens most commonly is that they say that those services are still subject to the deductible. So until you meet your deductible, you would be paying for your well woman visit or your mammogram or your birth control. What we have also seen are plans that limit coverage to generic birth control, meaning the generic pills. And then we see age, visit, or time limits on preventive services. And a quick example there is a plan that will say that you are covered for a breast pump, but you have to acquire that within 60 days of your child's birth. Or you can have lactation counseling services, but you have to get those within 4 weeks of birth. And then something that we also see a lot on breastfeeding, and this is particularly through our hotline, is that the plan itself has not established a provider network for lactation consultants. Now, they still have to cover those services as though they were provided in network, but the providers can do what's called balance billing. If the health plan pays less than we know what the lactation consultant charges, the woman can end up needing to pay the rest. And then the other thing that happens is that the woman has to pay up front and then try to collect from her health plan. So if you have a new mom who does not have the ability to pay out of pocket to start with for lactation counseling, it can be out of reach for her to get. And then last, we see a lot of administrative barriers to preventive services, such as requiring prior authorization in order to obtain a breast pump, which could delay getting your breast pump for several days, and that could be something that you need right away if you're having trouble initiating milk supply, or intrusive medical management. For example, telling women that they have to go through what's called step therapy, which is try cheaper versions of birth control before of the pill before they can get the pill that they really need, which is sort of a fail first strategy, which doesn't really work when failure can include not only side effects but also pregnancy. So next slide, please. So what can you do if you're having trouble with your health plan? Well, the first thing is you have appeal rights, and if you are experiencing this problem, or if you are working with women who are, we provide on our website some template letters that women can send in around preventive services. They can adapt them as they need them and send them to their health plans to appeal plan decisions and being charged cost sharing and that kind of stuff. Similarly, if you don't get the answer you're looking for from your health plan, you then have the right to appeal at the Department of Insurance level within your state. And if you have Medicaid coverage, often your Medicaid coverage will be through a Medicaid contracting health plan, and you have appeal rights there. But you also have appeal rights at the Medicaid agency. And under Medicaid rules, if you have been denied a Medicaid covered benefit, they have to provide that for you while your appeal is going through the process. And then lastly, and this is something more as advocates that we think of, is sharing your story. Those can be very powerful in terms of advocating at both the state level and at the federal level, and of course through the bringing attention to these issues through the press as well. And so on the next slide, one way to share your story is to go to coverher.org. That is our hotline for women who have trouble with birth control coverage and other preventive services. Women can go there and they can share their story with us. They can get help from our hotline coordinator and give us, if they are willing to, they can give us permission to use their story. Another couple resources that we have are on the next page. Our toolkits, which the one on the left is around birth control and well woman visits and screening for the BRCA gene mutations that increase the risk of breast cancer and a bunch of other stuff. And then a breastfeeding specific toolkit, which is on the right. So the addresses are up there, and those have a script that you can use to call a health plan and find out if your coverage is grandfathered. They have letters that you can adapt for your particular situation to send in as appeals. And, the idea is to provide women with the information to advocate on their own behalf or to help those who are working with them. And that's where I'm going to wrap up, and hopefully this has been a good introduction, and our next speakers will really help drill down on particular populations, and I'm going to toss this to Renee.
Hi, thank you. I'm Renee Butine, and I work at Advocacy Denver, which is an advocacy organization serving people with intellectual and developmental disabilities. And the reason I'm speaking to you today is because significant disparities in health and medical care utilization have been found for adults with intellectual and developmental disabilities relative to non-disabled adults. And we'll focus on women in particular, but before we do this, I'm going to give you a definition of intellectual and developmental disabilities. And after that point, I'm going to use the abbreviation IDD for the duration of the presentation. So intellectual disability is a below average cognitive ability with three characteristics, the first being IQ between 70 and 75 or below. The second is significant limitations in adaptive behaviors, so life activities like self-care, socialization, communication, etc. And the third is the onset of the disability occurs before the age of 18. And the second definition here is developmental disability, which includes people who have an intellectual disability as well as autism, cerebral palsy, severe seizure disorder, or severe head injury. And under federal law, DD means a severe chronic disability of an individual that is attributed to mental or physical impairment, or both, is manifested before 22 years old, and is likely to continue indefinitely. And the presence of a DD results in substantial functional limitations in 3 or more major life areas. Next slide. And so now we're going to move on to health barriers. One of the largest barriers we see among women with IDD is the access that they have to preventative health care. So a couple of statistics for you here. Only 28% of women with IDD received a Pap test in 2010, and only 46% of women aged 40 and over with IDD received a mammogram. To put that into perspective, one study found that these women were 45% less likely than non-disabled women to receive a mammogram and 72% less likely to have received a cervical cancer screening. So why? Well, there are a large number of reasons a woman may not receive care, but we can talk about a few of the biggest ones here. The first would be transportation. So many people with IDD are reliant on caregivers, public transportation, and/or in Denver, Access-a-Ride, which, if you don't know, is a local bus transportation for people with disabilities to get around. This means that oftentimes just leaving the home can take a lot of time and adequate planning. The next reason women with IDD don't receive care, and I think perhaps the most important, is communication. And this is communication with providers, as well as just having the ability to communicate an issue they have going on with their health in general. A woman may not have the language skills to express what she's feeling, essentially. So the ability to verbally communicate is a large barrier. Also, if you do have issues communicating, there's often limited funds for interpreters. Thirdly, if a family has abandoned a person, which sadly happens sometimes, or has passed away, then the medical history for that woman with IDD can be maybe limited or inaccurate, and they might, not be able to explain their situation accurately, their past situation. And the last barrier as far as communication goes is the anxiety around going to see a doctor, and this can look like unrealistic or excessive fears, avoiding situations or people, withdrawal or distress in social situations, or confusion. And any one of these symptoms would make it difficult to fully communicate with your doctor or vice versa. And the last barrier we'll talk about is the family and home one. And women with IDD living in residential settings, so this looks like a host home where
Hi, everyone. This is Karen Davenport. Greg asked me to get on and to say that they are working on the audio. Hopefully you were able to hear me since I am calling in from a different location. But they are at work on it, and hopefully we'll be back with the webinar very shortly. Thanks.
Let's try this.
Hi, I'm helping Amber Burkhart. Something must have happened and we have relocated to a different office. So hopefully you guys are all with us and can hear. And I think we're going to just backtrack a little bit and have Renee talk a little bit about going back and talking about some of the barriers.
Hey guys, sorry about that. Hope everyone can hear me this time around. This is Renee Butine, and I work at Advocacy Denver, which is an advocacy organization serving people with intellectual and developmental disabilities. I do actually want to go one slide back, and we're going to try and move along a little more quickly this time, but I have a, sorry about that. So we'll focus on women in particular, but before we do this, I want to give you a definition of intellectual and developmental disabilities, and after that point, I will go ahead and use the abbreviation IDD for the duration of the presentation. So an intellectual disability is an IQ, is a below average cognitive ability with 3 characteristics. IQ is between 70 and 75 or below. Significant limitations in adaptive behaviors, the ability to adapt and carry out everyday life activities such as self-care, socialization, and communicating. And thirdly, the onset of the disability occurs before the age of 18. And developmental disability includes people who have intellectual disabilities, as well as autism, cerebral palsy, severe seizure disorder, or severe head injury. Under, sorry, we're still working it out. Under federal law, DD means a severe chronic disability of an individual that is attributed to a mental or physical impairment or both, is manifested before 22 years old, and is likely to continue indefinitely. The presence of a DD results in substantial functional limitations in 3 or more major life areas. And so now we'll move on to health barriers, which is my second slide. There we go. All right, so a few statistics for you here. Only 28% of women with IDD received a PAP test in 2010, and only 46% of women over aged 40 received a mammogram. So to put that into perspective, one national study found that these women were 45% less likely than non-disabled women to receive a mammogram and 72% less likely to have received a cervical cancer screening. So why? There are a large number of reasons a woman may not receive care, but we can talk about a few of the biggest ones. The first is transportation, and that is that many women with IDD are reliant on caregivers, public transportation, and or Access-a-Ride, which, if you don't know, is a local bus transportation in the Denver metro area for people with disabilities to get around. So this means that oftentimes just leaving one's home to receive care takes adequate planning. The next reason women with IDD don't receive care, and I think perhaps the most important, is communication. This is communication with providers, as well as just having the ability to communicate an issue they have going on with their own body and their own health in general. Women may not have the language skills to express what they are feeling. So there's limited capacity to verbally communicate. There's also sometimes limited funds for interpreters if communication is an issue. Thirdly, if a family has abandoned a person, which sometimes sadly happens, or has passed away, then the medical history for that woman can be limited, lost, or inaccurate. And lastly, anxiety around going to see a doctor. And this could look like unrealistic or excessive fears, avoiding situations or people, withdrawal or distress in social situations, and confusion. And any one of these things would make it difficult to communicate or fully understand your doctor, or vice versa. And thirdly, there are family and home barriers. Women with IDD living in residential settings, so perhaps
We're going to speed up.
Oh,
So
okay.
we're going to speed up 2 slides. I guess I did hear this part of it.
Oh, you guys did hear that. All right. Slide 3. I think I know exactly where I stopped, which was in talking about barriers women with IDD face in obtaining sexual health care. And so I guess just note that being a potential victim is in part attributed to the vulnerability of these women, but also to the lack of sex education they receive in the first place. And in public education settings, students with IDD are often systematically excluded from instruction on topics such as contraception, family planning, sexual dysfunction, and the prevention of STIs and AIDS and HIV. So moreover, instruction on healthy sexual relationships and the prevention of sexual abuse and exploitation has been largely absent from the health curriculum designed for students with IDD. And people with IDD have also been viewed as asexual and purposefully misinformed about sexual health to reinforce fears about sexual activity. And attempts by the larger population to discourage or control any form of sexual behavior has really negatively impacted the sexual health knowledge, attitudes, and expectations of people with IDD. And young women with IDD are often treated as if they will never have an intimate relationship and can therefore be really ill-prepared if and when that time comes. Sexual abuse, sexually transmitted diseases, and unplanned pregnancies are less likely to be discussed and prepared for by young women with IDD until it's a little too late to have that conversation. My last slide here, just to move on quickly, is just a little bit of insight and the tools organizations can use to help women overcome these barriers. I will say the first ones deal with Advocacy Denver, so it's definitely Denver specific, but so we're working as an organization to help women and men with IDD become better educated about their health and wellness. Our healthcare advocacy program was created to help guide adults with IDD through the healthcare system, and we've been working to get the word out to provide education about chronic disease prevention and management amongst people with IDD and their providers. We're tabling. We hosted our first 9 health fair this past spring, and we also spoke to people at the Broncos Expo a couple weeks ago. We're just working also with existing organizations to offer health education classes in the community as well. And the last thing that we're doing is creating a sensitivity training to expose a variety of professionals to serving individuals with IDD. This training is still being perfected by our program coordinator, but it's our hope that we can help professionals be well informed about effective and respectful communication techniques when working with a large variety of populations, and this includes people with IDD. It's just our hope that better informed professionals will mitigate some of the anxieties people with IDD feel when receiving care. And the last resource I have for you is Women Be Healthy, which is an example of a really good curriculum for women with IDD who need help navigating the health field. Women Be Healthy is a website about healthcare for women with IDD, and you'll find information about things like breast and cervical cancer screenings, as well as like HPV, and how to just talk with your nurse or doctor. Their curriculum helps women prepare for visits. And there's also resources on here for caregivers, healthcare professionals, and case managers. And that is all I have for you guys. Thank you. Okay, I think we're going to take it to Myrna. Thank you.
Hello. Thank you, everyone, for the opportunity to talk today about something that is really near and dear to my heart. Latinos in general and people of color actually face many barriers to care. During my time with Boulder County working on women's reproductive rights, I saw firsthand many of these disparities. And we'll talk a little bit about those disparities today, specifically to Latino women and Latino community. Next. So on this screen, you'll see some of the barriers to accessing preventative services. I think one of the most interesting findings that we had over the last couple of years was through the Latino Adelante con la Salud Latino Engagement Project that was headed up by Melanie Herrera-Bort. In those groups that they conducted across the state, we were actually very shocked to find out that when they asked the Latino community what preventative services meant to them, a large number of them thought that it was something that they would be prevented from accessing. So these would be services that they would be prevented or barred from getting. So that to us was a huge shock, especially considering such a push in regards to the ACA and new health insurance enrollment to really engage community with the preventative services that were free. So we also see a huge need in the Latino community and Latino women in specific in regards to education, the utilization of benefits. And this, we understand this is a huge need because there is 1/3 of Latino women that are currently uninsured. We're also seeing some barriers in regards to our Latino community and Latino women understanding the difference between care, whether it's primary care versus urgent care versus emergency department, where you go. Sorry, guys, that's my paging system, and I have no way of blocking it. But where they go. And then we also see predisposition to disease. One of the reasons and one of the barriers that women tend to face in the preventative services is a huge predisposition to disease. Latina women are more likely to be diagnosed with breast cancer, unfortunately also at a later stage, and they tend to have tumors that are harder to treat than white women. And in the Latina population, we also tend to get cancer at a younger age, which can be very intimidating and really hard to diagnose when we're not getting that preventative services and those free services that we're now eligible for through new health insurance. Latina women are also the highest rate of the cervical cancer group, and they're also more likely to die from cervical cancer than any other ethnic group. And we're also 4 times more likely to have HIV/AIDS versus white women. This, of course, is a huge barrier culturally. Sex, sexuality, birth control, our bodies, these are not conversations in Latino culture we have very openly. There's a lot of stigma associated with these conversations. And there's a lot of discomfort and lack of facts and information in regards to these topics. In other disparities, we also are more likely 1 in 10 after the age of 50 to have osteoporosis, and we're twice as likely as white women to have diabetes. Again, that lack of preventative care. We're also more likely to contract chlamydia and gonorrhea than white women, and again, 1/3 of the Latino women are without insurance in this current area. So what are some solutions and efforts? Definitely one of the things that we have seen a bit of an increase on is education that is tested by the community. Some of the focus that we conducted back in June, thanks through financial support from CHI, we saw that some Latino women actually have fear about utilization of benefits. They're afraid of utilizing their new insurance coverage because they're afraid of what kind of bill they're going to end up with. And this is really word of mouth. We always joke about it, but I think it's very true. In the Latino community, you talk to one person, make them happy, they're likely to refer another 10 to 20. You make them unhappy, they're likely to turn that story into a horror story for another 10 to 20 individuals. So it's really important for us to use education that is tested in the community, whether it's through town halls, focus groups, women within organizations that you work with, that really provides the language, terminology that is clear and concise and that is very simple. I know that when we're talking about English language brochures, we often talk about a 5th grade level. With a lot of our Latino community, we're actually looking at a lower grade level than that because we have such a huge, huge difference in socioeconomic, education, backgrounds, and areas where they come from. And what do we mean by prevention? The education of having people understand what prevention means. So a lot of the language that we're currently using is talking to women in regards to the free services that can prevent more serious issues or more serious health conditions, instead of calling it preventative services. We know that it's really not a positive thing for the Latino community. We're also seeing a movement in providers to continue to diversify their workforce, whether it's hiring from the communities they serve, trying to depend more on interpreters instead of a language line. But we definitely have a lot of work to do. We still need to see some policy changes. We do also need to create more opportunity for use of color to enter these fields. And we also, I think, need to continue having these conversations at the community level. So how do we frame the national conversations going on about women's health to the community perspective? I think we're all very aware of a lot of the attacks that are going on women's rights, reproductive justice at the national level. So how do we have these conversations, and why should we have these conversations with Latino women? Part of it, again, going back to the cultural piece, where these are conversations that we're not having in our families. So it really do depend on the community organizations like Moral and Color, to be able to bring those conversations to these Latino women. And again, the engagement in the community. We always talk about multiple touches. It requires at least 4 to 7 conversations with an individual in order to get them engaged in the topic, and multiple approaches, utilization of media, utilization of one-on-one conversations, through presentation. So really thinking outside the box as where we're going and making sure that we are the ones going to, because Latino women and Latinos in general, we're not the type of community that will come just because you built it. You really do have to come to us, approach us. And I think Amber would be next.
Hi.
Hi, this is Amber Burkhardt. I'm sorry, we're having a few more technical difficulties. I will be using a cell phone, so I really hope that you can hear. Please text back if you cannot hear us on this line. Okay, great. So as I said, my name is Amber Burkhardt, and I know that we're getting close to 1 o'clock, so I will try to rush through this a little bit, but I hope you find this information beneficial. So I will be talking today about a complex barrier that dependents often face when seeking out access to confidential health care services. A dependent is a spouse or child who relies on the primary insured member for health coverage. This could be your own high school daughter or wife. The ACA now allows parents to keep their adult children enrolled in their plans until the age of 26. Often these children are referred to as adult child dependents, and I will talk about this in a little bit. So patient confidentiality is widely accepted as a fundamental tenet of healthcare, and is particularly important for women and adolescent girls who are seeking out sensitive healthcare services. Many women are not aware, however, that private health insurance plans can send an explanation of benefit statement that details the service that is used to the primary policyholder. Again, this is often a parent or spouse. Explanation benefits, or as I will refer to them as EOBs, these statements help policyholders better understand their insurance benefits and track their insurance utilization and healthcare costs. EOBs are important because they provide transparency and accountability to policyholders. These statements also provide detailed information about who sought the service, the date of the service, the provider name, and the type of service that the individual sought. And this can unfortunately be very problematic for dependents who are seeking sensitive health care services and want to preserve the confidentiality of their health information. In a 2013 Kaiser Family Foundation Women's Health Survey, they found that women among the age of 18 to 25 said that only 71% of them believe that confidentiality is really important, but only 37% of these women knew that private health insurers typically send an EOB. So you can see the stark difference between the importance and value of confidentiality and the knowledge that these EOBs are sent back to policyholders. So this policy from carriers has broad implications for various populations. This issue, for example, can impact individuals seeking mental health services, substance abuse disorders, testing or treatment for potentially stigmatizing conditions such as HIV or AIDS, reproductive health services, domestic violence or sexual assault screenings and services, and services related to an individual's sexual orientation or gender identity. Many of these services are deemed sensitive, are also included in the copay-free preventative services that we have talked so much about with women. So, unintended consequences from these EOBs are as follows. For example, imagine a college student who wanted to seek out testing for sexually transmitted infections after having unprotected sex. But the college student was afraid that their parent might find out, so they decided to forego care. This could unfortunately lead to an untreated sexually transmitted infection. Or imagine a high school student who is feeling really depressed and having problems with her family. She wants to seek mental health services to talk about her family and how she's feeling, but doesn't want her parents to find out. Delaying or foregoing care could result in an undiagnosed mental health condition. Something else that's really important to note is victims of intimate partner violence. These individuals can often face serious physical and psychological danger from policyholders finding out about an EOB. For example, we received a story recently about a woman in Colorado Springs who went to get birth control but didn't want her spouse to find out. When her spouse found the EOB, she was hospitalized due to physical harm. In other cases, a dependent may decide to seek care but go to a safety net clinic to avoid using their own health insurance. And as a result, this increases the cost and burden on the public health system, safety net system, when care could otherwise be paid for by private plans. These are just a few stories that illuminate why protection of dependents' privacy is vital to their health and safety. So recognizing the importance of ensuring confidentiality for dependents, the Colorado Division of Insurance addressed this issue in a regulation in 2013. The regulation states that health insurance carriers must take a reasonable step to ensure the protected health of any adult child or adult dependent who is covered under the policy is protected. Unfortunately, this regulation does not cover minors. An adult child dependent, which I referred to prior, must be between the age of 18 and 26. In addition, the only federal policy that addresses this issue of confidential communication directly is the Endangerment Clause, which is embedded within the Health Insurance Portability and Accountability Act. Most people know this as HIPAA. This clause states that health plans must accommodate reasonable requests by patients for alternative communications if disclosure would endanger the requester. This is a very important policy that provides a greater protection for victims of intimate partner violence. So how can we make sure that women have access to these important confidential services and feel empowered to be active in their healthcare decisions? One is we need to make sure that women know their rights when it comes to confidentiality and EOBs. Oftentimes, they just don't know very much about EOBs, how they work, or if they do not feel empowered to exercise their rights. More public awareness about practicing of sending EOBs and the protections available to women is very critical. Women also need to speak with their providers. Providers understand these obstacles that women face in terms of confidentiality, and they can help them navigate through these barriers. Women also need to contact their carriers and ask questions. As I talked about the regulation prior, this regulation is interpreted many ways by different carriers, and therefore this makes the process in place to protect adult dependents different among all different carriers. For example, a carrier might require the adult dependent to call prior to an appointment and request that the appointment remain confidential. Or the carrier might instruct the adult dependent to use the online member portal to add an alternative physical address to which an EOB should be sent. Even though this regulation does not include minors, minors should also talk to their providers and carriers as well. Oftentimes, in some of the carriers in Colorado, they do have protections for minors, and therefore minors really need to feel empowered to ask questions. And for advocates like myself, we need to work with policymakers to ensure that carriers in Colorado and across the nation are taking steps to ensure confidentiality for dependents and to make sure that we find solutions to better ensure confidentiality is protected for minors. Women of all ages should be able to get the care they need without thinking about concerns about confidentiality. All right, so that concludes our guest speakers, and I just wanted to let you know, I know it's nearing 1 or a little after 1 p.m., so thank you for all of those participants who are still on the line. I want to let you know about a resource that CCHI, Colorado Consumer Health Initiative, has created. As you can see on the screen, it's a checklist for women for their copay-free services that they can fit in their pocket or purse. It's a 4x6 material, and it's also not only in English but in Spanish. And you can see on the screen that you can contact Emily Michaels for more information, and we are happy to send this resource to all the participants free of charge. Our hope is that through this resource, we can help spread the word about these really important preventative services that we've talked about today. So now I think we're all going to stay on the line and answer any questions, but thank you everybody for taking the time to listen to this important webinar today. And you can see on the screen there are the contact information for all of the guest speakers. If you have any questions, please reach out to them.
Just want to thank everyone again for bearing with us with the technological difficulties. And if you have any questions, please feel free to submit them, as I see some folks are doing now. And someone would like to see Emily's email address again, and that's just emichaels@Colorado or cohealthinitiative.org. Any other questions we have for our speakers? You can reach out to individual presenters, or you can reach out to us right now and ask any questions you have. So we have some resources in Spanish, in particular the last one that Amber spoke about. And also, Mirna, can you answer any questions about other Spanish materials the servicios offer?
Okay, so we have very minimal outreach material. Haven't really printed anything new, but we did have this really great tool that was developed with Adelante con la Salud Latino Engagement Project, where it explained the different types of insurance, it explained the terminology of like co-payment, co-insurance. I can send the electronic file, and organizations can definitely decide if it's something that they would like to print.
Great, thank you for that. We also had a question that was if an individual wants to get off their parents' insurance, what would be the best way to do that? If a minor, in particular, wants to get off the parents' insurance. And I'm wondering if anyone has anything they could add to that.
This is Karen. One thing that, well, if they are a minor, it would be, they would not qualify for tax credits on their own. Depending on their state, they may qualify for Medicaid coverage for family planning on their own. If they are not a minor, but they are, filing their own tax forms and are currently on their parents' coverage because they're under 26, they can drop that coverage and shop in the marketplace and qualify for tax credits on their own. They would need to time that to coincide with open enrollment, though, because dropping off of your parents' insurance does not qualify as the kind of event that would allow you to get a special enrollment period. So you need to do that just within the open enrollment, which will be beginning November through end of January this year.
Okay, and Karen actually just specified they were looking a bit more to just not use their parents' insurance in case of sensitive procedures or whatever they may be looking for. So I misphrased that, not get off the insurance, but can they go to a Title 10 clinic or something like that and get birth control or something that their parents don't get an EOB?
Yes, they can absolutely do that. And as I mentioned before, they, in many states, will qualify for Medicaid coverage for family planning services as a household of their own. So and a Title 10 clinic would help them do the Medicaid application for that kind of coverage.
Perfect, thank you. And then, Renee, we do have one for you. Is Women Be Healthy specific for women with IPD, or is it designed for all women?
Sure. So I think Women Be Healthy is marketed kind of specifically for the healthcare of women with intellectual and developmental disabilities, but I would say that it's not specific for any one woman. I mean, there are great, resources on there for mammograms and pap tests and all the things that every woman needs. So I'd say that, the more people that utilize a tool like this, the better.
Okay, and the next question we have, is there any way to reroute an EOB or any move to obfuscate the nature of services rendered?
Hi, this is Amber Burkhardt again from Colorado Consumer Health Initiative. I'm going to also touch upon someone else's question that was earlier, is if you are trying to reroute an EOB and speaking with your carrier, do you need to reference to the HIPAA clause? And what I'd like to say about that is that, it really depends on what state you are in. The HIPAA, unfortunately, it is only protected for individuals who claim endangerment. So if that was a case of any case of intimate partner violence, that individual would be afraid that they would be endangered by disclosing that information, that is when you would want to reference HIPAA rule. Unfortunately, in other cases, you cannot use that. So what you would want to do if you are in Colorado, if you do fall into that adult child dependent or adult dependent, you could reference the regulation, and we're happy to send out all of that information after the webinar. This webinar is also recorded, and you'll be able to see the regulation that is on the slide as well. And you would want to just ask, what is your carrier doing to ensure confidentiality for adult dependents?
All right, if we have any other questions for our speakers, please submit them. And I did want to put in a plug for our webinar next month. We'll be joined by Catholics for Choice, and that is going to be on October the 28th. So Wednesday, October 28th at noon, we'll be joined by Catholics for Choice and discussing some other choice issues. So any other final questions for our speakers today? Doesn't look like we have any. So thank you, everyone, for being able to participate today. I appreciate all the questions, and one big round of applause for all our speakers. Thank you, everyone.